Let's move to the last speaker of this session, who's Javier Kulisevsky from the Institut de Recerca Hospital de la Santa Creu, São Paulo. He's also a member of CIBERNED, and the title of his talk is Treatment of Cognitive and Neuropsychiatric Impairment in Parkinson's Disease, an Unmet Need and a Methodological Challenge.
Okay, thank you, the organizers, for this kind invitation. And I'm also a clinician, as Dr. Tolosa said this morning, and I'm going to talk about clinical issues. And I think in this kind of meeting, it is important to give a clinician perspective that, from my point of view, is a more integrative one, and we need more communication between basic and science and clinicians, because our patients are not a partial problem. They have many of these problems, and Parkinson's disease has evolved in the concept of what it is. It is not only a motor disease, it is a non-motor disease, and this is not very old as a conception. In the next 20 minutes or 25, I'm going to talk about some behavioral and cognitive problems of Parkinson's disease. The spectrum, you know, include anxiety, depression, hallucinations, apathy, and different degrees of cognitive impairment. But overall, treatment resources for these kind of symptoms are poor, and the quality of evidence generated by clinical trials are also poor. From all these problems, I will focus more on apathy and cognitive impairment that are the most directly related to PD progression and the two most unserved symptoms in the sense of having opportunities to improve them. And some, finally, lessons to be learned from recent RCTs on apathy and cognitive impairment. Then, behavioral and cognitive symptoms are highly frequent in Parkinson's disease. They are important cause of distress and disability. Initially, it were considered a late complication of Parkinson's disease, but nowadays we know that they are present from the very early phases, even in the premotor phase of the disease. They frequently combine, and some clearly worsen as apathy and cognitive impairment with the evolution of the disease. Detection is invaluable for clinicians to accurately identify individuals with these conditions and to provide timely and efficient treatment to revert or alleviate symptoms. It is important to know, and also for you, that we have a lot of resources to improve motor function and very much less resources to improve these cognitive and behavioral symptoms that are very distressing both for patients and caregivers. This is just to show you that the profile of neuropsychiatric complications of Parkinson's disease is very similar between patients without dementia and patients with dementia. Both may have hallucinations, depression, anxiety, apathy, but the only difference is the severity of the problem, but not the profile of the problem. And that tells us that this problem begins from the very early in the disease. These are the symptoms that cause more distress in newly diagnosed patients, and you can observe that the symptoms that most frequently cause caregiver distress is apathy, depression, anxiety, irritability, and they are more important than the motor problems that in the very early years and along many years of course of the disease impact both the patient and the caregiver. Anxiety is very important. It is a frequent comorbid symptom or maybe a presenting symptom of the disease that can antedate motor symptoms by many years. and also can be an off-period phenomena, and it is not always easy to differentiate whether it is true anxiety related to the disease or a fluctuation in anxiety that is caused by the oscillation of plasmatic levels of levodopa. We use antidepressants, and many doctors use also benzodiazepines, but there are no randomized clinical trials to test their efficacy in Parkinson's disease, and this is important also for you to know. And we use, or many doctors use benzodiazepines that are associated with undesirable side effects, reduced cognitive function, balance problems, sedation, and they may increase the risk of falls. And in spite of this, some patients still require benzodiazepines for managing their symptoms of anxiety. Depression is very frequent, but the frequency of, or the prevalence of depression along the course of Parkinson's disease is more or less stable. Up to 50% of subjects at some point have depression, but it's not a symptom that increases in severity along the course of the disease. It is also a major factor for health-related quality of life. It is linked to cognitive impairment. If you have depression, your performance from a cognitive point of view is worse. It also can be a prodromal symptom in Parkinson's disease, many, many years. Also, late onset depression in the general population may precede the diagnosis of Parkinson's disease. Both depression and anxiety are comorbid many times, and this comorbidity greatly exacerbates PD symptoms. Regardless of the clinical severity, it is important that symptoms of depression are recognized by the doctor and require treatment. Here you have some examples of randomized controlled trial, but many of these have not depression as the main objective. That is, we have poor data, but in spite of this, treatment with SSRIs are efficient in patients with Parkinson's disease, and the pharmaceutical industry is not very much interested in making a particular trial of depression in Parkinson's disease. Important, dopamine agonists have been implied in improving depression, and many times they are consulted in patients with depression. If you see the magnitude of the effect, of course, there is mood problems and noradrenergic and dopaminergic problems that affects the mood in Parkinson's disease, but are not so efficient as SSRIs, as the conventional antidepressant treatments. Overall, there is a paucity of good quality evidence, and you have to be cautioned to treat depression with dopamine agonists because you can increase the probability of having impulse control disorders that can be a social catastrophe for patients and families. Going to psychotic symptoms, the most frequent symptoms are paranoid delusions, but more frequent are visual hallucinations, mainly visual in Parkinson's disease. Also, they are minor hallucinations that are difficult to define in the sense that the patient has not explained absolutely precisely what is he or she experiencing. Sometimes it's a sensation that there is someone in your back or someone passing by. And this is the most prevalent hallucination and the earliest type of hallucinations in Parkinson's disease, and even can be a premotor phenomenon. Having hallucinations, of course, formed hallucinations with insight still maintained or insight lost, is the strongest single predictor of dementia developing in the context of Parkinson's disease. And we have to be alert to ask for this presence of hallucinations even from the premotor phases of Parkinson's disease that were discussed this morning. And also reflect in the very early patients having minor hallucinations, gray matter loss, and also they predict subjective decline. What we have for psychosis, more or less the same that we have for treating behavioral problems in Alzheimer's disease or other dementia. And if we need to use some antipsychotics, we have no evidence for any of these, provided pimavanserin, that is not marketed in Spain, is the only one antipsychotic that has some evidence. And we are all using these drugs out of label. Apathy. Apathy is one of the more common and debilitating neuropsychiatric disturbances in Parkinson's disease, also in DLB, and it is a quantitative reduction of goal-directed activity of motivation, as the last speaker talked, in the sense that the relevant signal that is going through the basal ganglia to the cortex is not validated by the basal ganglia. It arrives with a weak intensity, we can say, and it conditions different types of apathy that can be emotional, that can be a cognitive apathy, an autoactivation deficit, and it increases not only the problems of patients, but make a lot of distress of the caregiver, and it is a signal or a bad signal to develop dementia in Parkinson's disease. Prevalence is up to 70%. It is present in at least 20% of early patients, in de novo patients, and in up to 50% of non-demented persons with established PD, and can be properly identified using appropriate instruments such as the apathy scale or the Lille apathy rating scale. It is different from depression, and for instance, talking about dopamine, isolated apathy, it is important to study patients that has only apathy, not depression. They exist, are not easy to separate, but with the adequate instruments you can. And you can see that these patients show not only problems in their dopaminergic pathways in the sense of nigrous striatal or BTA, mesolimbic, mesocortical, but also show a widespread reduction of extrastriatal dopamine uptake, and this is a comparison of apathetic patients to non-apathetic patients. That is, abnormal dopamine depletion might explain, at least partially, the increased risk of apathetic patients developing cognitive impairment or dementia, because for cognitive impairment and dementia, you need more than a nigrous striatal depletion. Of course, dopamine is not the only neurotransmitter that is altered in apathy. What we have for apathy, almost nothing. It is the most unserved neuropsychiatric symptom, and only 3 high-quality randomized controlled trials. One with dopamine agonist rotigotine was negative. This with piribedil, that is another dopamine agonist marketed in France, is tricky because these patients were patients going to ST and DBS that were withdrawn from the dopamine agonist, and then they develop apathy. And if you put a dopamine agonist, perhaps they are going to recover. Then it is not a good RCT. Also, there is a trial with rivastigmine showing some improvement, but it is not maintained. And the MDS evidence-based review say that we have nothing for apathy in Parkinson's disease. Perhaps abnormal glutamatergic transmission, besides dopamine, perhaps besides acetylcholine, is or may partially contribute to apathy in Parkinson's disease. Glutamate transmission becomes hyperactive following dopamine depletion, and a glutamate hypothesis for apathy, at least partially implied, arises from some trials in psychiatric patients that I'm not going to enter. We have this drug that is safinamide, is a MAO-B inhibitor, but also is an anti-glutamatergic drug, and perhaps this dual action of a drug that reinforces dopaminergic transmission and blocks the effects of pathologically elevated levels of glutamate may conceivably improve the synaptic connectivity that trigger the functional recovery of the damaged network that is typical for apathy. Then we did this study. It is very recently published, and it was a 24-week, two-center, randomized, double-blind, placebo-controlled trial. And important, for enter into the study, you have to have clinical criteria for diagnosing apathy in clinical practice, not even use apathy as another scale to use in a post-hoc analysis. And they were randomized 1-to-1 to safinamide or to placebo, and the primary efficacy endpoint was the apathy scale. The planned sample was 36 patients, but we also had 27 for the final analysis because the COVID in the middle caused a lot of problems, and we ended the study before recruiting the total sample. But in spite of this, from a statistical point of view, it was valid. Here you have the demographic is more or less the same as a normal population of Parkinson's disease. And going to the point, the primary efficacy analysis using ANOVA showed a trend to significance in the main outcome, that was the apathy scale, based on a more marked decrease on apathy scores in the safinamide group than in the placebo group. Importantly, there were no changes detected for the other secondary outcomes except for the only item of the NPI of the neuropsychiatric inventory that changed, that was the apathy item of the safinamide group. And when we used the post-hoc Pirate test, we observed a significant difference, not in the first 12 weeks, but a significant difference beginning on the 12-week until the 24 that favored the safinamide group in a sense of an improvement of apathy. And also we can show here how there was a significant decrease in the mean apathy severity score in the safinamide group. That is, this is a difference in the rate of conversion from clinically relevant apathy to non-apathy. Well, something happens here. Siguiente. Okay. Then, overall, safinamide was safe and well tolerated, and there is a case in this study for a possible favorable response with a delayed initiation of action and a more consistent benefit improving apathy with a longer duration of a study. Then we learned a lot of things for future studies, and we observed this positive signal. Last, cognitive impairment. Then cognitive impairment in Parkinson's disease is inherent to Parkinson's disease. It is, you have a lot of problems with dopamine, with the nigra, but there are a lot of things that conditions you to have cognitive impairment, and perhaps this is presently the most important from a behavioral and cognitive point of view, and the danger that if you have Parkinson's disease, you can improve with dopaminergic drugs, you can use STN-DBS, a lot of new ways of treating patients, but cognitive impairment is important in the sense that we have nothing to treat this. And it begins with subjective cognitive complaints that can be added to these premotor and early phase symptoms, goes to relatively subtle cognitive impairment that is mainly dysexecutive and linked to dopamine deficit, goes to mild cognitive impairment that is clearly defined by the MDS task force on mild cognitive impairment, just to homogenize future trials in mild cognitive impairment, and lastly goes to PD with concurrent dementia that is mainly caused by a crucial contribution of non-dopaminergic systems, mainly cholinergic, and progression of pathology, Lewy bodies, synaptic neuronal loss, amyloid and tau pathology, vascular disease, and inflammation. Then this is prodromal dementia, and you can identify people who is at risk of going to dementia using the task force recommended scales or comprehensive examination. Then what is important is to know that at the first, the main problems with dopamine lack are dysexecutive, and this may improve at least in the first or second year of treatment, and thereafter they decline. And when you enter into this transition from mild cognitive impairment to dementia, characteristically, you have not fronto-subcortical deficits, that is working memory, executive problems, but you develop cortical, posterior cortical signs, memory, visuospatial impairment, language impairment, and this is captured by the valid and reliable instruments like this scale that is the PDCRS. But still, this is the only double-blind study that was considered to approve a drug for cognitive impairment in Parkinson's disease, only rivastigmine, but for demented patients. It was published almost 20 years ago, and still we only have rivastigmine as considered as efficacious, but only for Parkinson's disease dementia, not for mild cognitive impairment. We have no approved or recommended treatment for PDMCI, and we are in an urgent need to develop these kind of trials. But if you see more or less what is in developing in Parkinson's disease trials, there are no many trials with these. Some of these are no more running. And for instance, from these nine trials listed here, only one primary measure is used in more than one trial. That is, we have a methodological problem because some trials use the Cantab battery, others use some test of working memory, others use the CDR computerized method. For instance, this phase 2 trial, relatively recent with this cortical enhancer, that is a compound that supposedly enhances cortical norepinephrine, dopamine, and acetylcholine, the three at the time. It was a 4-week treatment only in patients with PDD, and the outcome was this Cantab battery, and they only detected among many tests only a slight improving in one of the subtests of this battery. Then it is difficult to compare with other studies. Another compound also used only for demented patients is this Anavex. It was recently presented at the ADPD and other congresses. And this is a sigma-1 receptor agonist and mechanistically focuses on a new target that is not the usual ones. And in this study, cognition was measured with the CDR computerized assessment, and they we observed some statistically significant and dose-dependent improvement in episodic memory and attention. But I was not implied in the design of the study, but we conducted a great part of this study. I put this in the sense that perhaps we need to make and to think that the patient is very important. Cognitive impairment is progressive in Parkinson's disease and may be taken, and this is my point, as perhaps an outcome measure in studies of progression of Parkinson's disease. That is, disease modification is the ultimate goal for preventing cognitive decline. And for instance, inflammation is very important, and this interaction between inflammation and alpha-synuclein is worth to explore. Of course, there are some studies exploring inflammation in Parkinson's disease, but they are all in early stages and are not using cognitive outcomes as primary objectives. And then a few years ago, we read with interest and we contacted with José Luis Lanciego and José Luis Lavandeira, and they told us, you know, there is some inflammation in PD patients that if you, there is a major mechanism of alpha-synuclein toxicity and microglial activation that is mediated by the overexpression of alpha-syn. And there is an increased expression in these tissues of angiotensin type 1 receptors and other problems, but this was remarkably, and they told us perhaps they can be, and they demonstrated it in cultures, that a simultaneous treatment with angiotensin type 1 blockers, candesartan or termisartan, that are antihypertensive drugs, may be neuroprotective strategies for Parkinson's disease. And then we work in this CIBERNED-supported trial, and then we presented it in the ADPD and also in the next meeting of movement disorders. And this is a proof of concept just to know whether there is safe to give candesartan to PD patients. 28-week, single-site, double-blind, placebo-controlled, of course, with all the ethical measures. We recruited 36 consecutively patients with different degrees of cognitive impairment, from subjective cognitive complaints to mild dementia. We give them candesartan. We explored safety and efficacy measures, and the main efficacy outcome was the only one specific PD scale recommended by the MDS to explore PD-MCI patients. And some secondary outcomes were some test, mood, and apathy measures. Then 30 subjects completed the study, 14 in candesartan, 16 in placebo. It was well tolerated. Specifically, there was not worsening of motor or behavioral status, and the ANOVA analysis revealed no significant differences in the primary outcome, that was global cognitive status, and no difference in other measures except for apathy. And then in the ANOVA, we observed that treatment with candesartan, but not placebo, was associated with a significant improvement on apathy scores as measured with the recommended scale, that is the apathy scales. That is, what we can tell of this is that candesartan appeared to be safe and well tolerated, although it produced no objective differences in global cognitive status. Attending to the candesartan mechanism of action, this failure may be both due to the relatively short period of study or to the advanced stages of cognitive impairment in many patients. But the positive signal of improvement on apathy scores that is strongly related to cognitive impairment, we think that deserves further studies. Then, as a conclusion of this talk that wanted to be a translational one and motivated you to propose to us, to clinicians, to explore with the adequate measures and not only with some partial measures that are not comparable, what can we do for all these neuropsychiatric and cognitive spectrum of symptoms in Parkinson's disease. Then, as conclusions, we have acceptable symptomatic treatments for anxiety, depression, and psychosis, although the quality of evidence is generally poor, and until presently, pharmaceutical industry prefer post-hoc studies of non-motor studies, and you will find in the literature a lot of improvement of apathy, improvement of cognition, improvement of depression, improvement of the non-motor scale, and all are post-hoc analysis of motor studies that have not including these problems as the main issue to study. Treatment of apathy and cognitive impairment in non-demented PD is an urgent unmet need. Disease modification is the ultimate goal for preventing both apathy and cognitive decline. Perhaps increasing understanding of neurobiological changes will help to implement a roadmap of tailored interventions for patients with PD suffering clinical apathy and cognitive impairment. But from my point of view, cognitive impairment, more than motor impairment that is measured with the UPDRS and is affected by dopaminergic treatment, should be incorporated in upcoming randomized control trials addressed to progression of Parkinson's disease, both as primary or as a co-primary outcome measures, because it is a more clean measure of progression. And there is a huge variability in the cognitive measures used in cognitive studies until presently, and it is important to know that there are validated and reliable MDS-recommended instruments for scoring both apathy, cognitive performance, and importantly, the functional impact of cognitive impairment in PD. And there are FDA-recommended pathways for studies in mild cognitive impairment. Then I think that both basics and clinicians should make an alliance to further study these important issues for our patients. And many thanks for your attention.
Thank you, Jaime. Questions from the audience? We have one back there.
Thank you for your talk, nice talk. I am focused on ALS, and apathy is also an important symptom nowadays. 1/3 of patients with ALS has apathy, and it means a worse prognosis for our patients. So do you think safanimid could be a possible drug to test on ALS patients with apathy? ALS with apathy, because apathy is also an important symptom nowadays in ALS patients.
I think that apathy is different from depression in the sense that it is not so heavily impacted by emotion and the social situation and the subjective feelings of the patients. And when you see apathy, for instance, in a patient with ALS, perhaps it is telling you that somehow more than the motor system is affected in these patients. And we presently know that there is not so frequently and not so important as it happens in Parkinson's disease, but in ALS is also cognitive impairment and of course some behavioral abnormalities. And also there is this link with frontotemporal dementia. Then ALS is not only one disease, again, it has many things that you know more than me, but apathy is also an important issue because these patients has a very short expectancy of life in general, and then we have to have something to offer. And perhaps if we have some drugs for Parkinson's disease, we will have some effective opportunities for ALS and also for Alzheimer's or DLB patients that suffer apathy in a very important, very frequently.
Well, thank you. We already finished this session, and I thank all the speakers, and I remind you that we have to be back at 5 after coffee.